Thanks guys, welcome. Hopefully I don't look too dreary-eyed, and welcome to the Journal Club for November for London's Air Ambulance. Nice to see so many of you, and thanks to those that have joined us from afar. Today we're going to be looking at this paper here, which is a subgroup analysis of a paper that I'm sure many people, probably all people on the call, have probably read. It's the association of pre-hospital plasma with survival in patients with traumatic brain injury, published in JAMA. What I thought we'd do is just jump back just to what the initial trial of the RCT was, which was the PAMPer cluster randomized control trial, because it's a secondary analysis or subgroup analysis of that. And just to remind people what PAMPer was, just so we're all on the same page before looking at this particular paper. So PAMPer, the clinical question was, in severely injured patients at risk of hemorrhagic shock, does pre-hospital plasma resuscitation compared with standard care resuscitation reduce a 30-day mortality? And in their plasma arm, they gave 2 units of thawed plasma initiated in a pre-hospital setting by air transport teams based at a number of US air transport services, 27, I think. It was a phase 3 RCT. It was a cluster randomized trial, which pragmatically seems like an appropriate thing to do in this, and there's a number of inclusions and exclusions there. Randomization was of air medical services and not individual patients, and it was block randomization for 1 month at a time with plasma arm and then standard arm, which was a control arm. Randomized over 501, as you can see there, plasma of 230 with a primary outcome looking at 30-day mortality, plasma of 23%, 30-day mortality with standard care 33. So fairly significant change, and certainly a paper that many people have looked at in quite a lot of detail. If we just look at some of the strengths and limitations that a number of different journal clubs, a number of different people have analysed, looking at this, the strength of the original PAMPer trial and the limitations, I think, is important to understand and think about before we look further into the subgroup analysis, so we're not clouded by it. But the strength of this paper is pretty good. It's asked a really clinically important question. It's a pragmatic, multi-centre RCT. It had predefined subgroup analysis, so its analysis plan right from the start was pretty solid. And the personnel assessing the trial outcomes were in fact blinded, although the pre-hospital clinicians were obviously not blinded, which was one of the limitations. Limitations also, study groups were slightly imbalanced in the volume of crystalloid and patients receiving red cell transfusions, and there's some people think that's probably biased the results slightly, maybe exaggerate the results possibly. And inclusion on transfer patients in the trial risked introducing bias, that should be. It's not clear in some of the patients where they actually received some of the products when there were secondary transfers involved. But on the whole, PAMPer's a pretty solid trial that just didn't have perfect blinding because it couldn't really, but it's a good one, good place to start. So looking at this subgroup analysis, the background is that they wanted to take the PAMPer data and patients and really look at that subgroup in relation to traumatic brain injury. We know that traumatic brain injury is a leading cause of preventable death worldwide, and we know that PAMPer demonstrated that improved 30-day mortality by 10% in the severely injured patients at risk of hemorrhagic shock, and they got given plasma pre-hospitally. We also know that from retrospective work and animal data from the labs, it suggests that plasma might actually have a favourable outcome in some traumatic brain injuries, but there's not been a huge number or any really decent RCTs to prove that point, and this was a good place. It's a good thing to do a subgroup analysis on this group of patients, probably. Is pre-hospital plasma administration associated with improved survival among severely injured patients with TBI was their ultimate question in this subgroup, but obviously right from the start they were well aware, because it's a subgroup analysis and they've already put people into different groups, and this is a hypothesis generating only and unlikely to be a game changer with respect to translational practice, but certainly they hope to go on to ask some more questions and inform further RCTs. The methods picked out of this study is, as on the slide really, it's a secondary retrospective analysis of the predefined group from the original data. The subgroup is traumatic brain injury. As I say, it's predefined in the subgroup analysis, so this is not a group of people sitting around looking for causation, looking at lots of different things and finding there happens to be one here. They were always going to look at traumatic brain injury. They analysed the data and those dates there. The initial PAMPer study was obviously not designed for traumatic brain injury, but it it was a good study. The protocol was defined as an AIS score of greater than 2 in the initial PAMPer study, and that's how they identified traumatic brain injury. However, one change that is noticed when you dig into this paper a little bit, that in this subgroup, they don't actually use that. In this subgroup, they widen the field out slightly, and they define traumatic brain injury as defined by a radiologist on initial CT. So to fall into the traumatic brain injury arm of this subgroup, you need to have something on CT that a radiologist thinks is equal to a traumatic brain injury, which we'll talk about in a minute, because there's some traumatic brain injuries that might have initial CTs that don't look too bad, which might confound these results slightly. If we look at the patient selection flowchart from their paper, the groups are pretty relatively evenly distributed. The way they've laid this out shows how transparent they're trying to be. They've got everyone randomized off into their initial PAMPer groups, and then within those plasma and standard care groups, they show again how many people have traumatic brain injury and non-traumatic brain injury, and also their associated patients that are lost to follow-up, which is equal in both groups, and not that big comparatively, considering the cohort of patients they're looking for. The one group of patients that I'm not entirely sure on here are the patients with traumatic brain injury that never went on to get a CT head. I'm not entirely sure if they died prior to that. I'm not entirely sure where they fall within their data set, which we'll talk about in a minute. The table 1 in their subgroup analysis paper is a comparison of patient and injury characteristics and outcomes across patients with TBI and not TBI, which is interesting for a table 1. And then their table 2 goes on to actually look at the comparison data amongst patients with traumatic brain injury across groups of pre-hospital plasma trials. Then it looks at standard and non-plasma in their table 2 of the patients that had plasma. The one thing, these are really small, you don't expect you to read them. The groups are relatively well evenly distributed, and they're comparative across the two, which is pretty good, and they're very transparent in what they've shown here. There's not a huge amount of particular points to pull out, apart from if we zoom down on the outcome data at the bottom, because we're trying to get to a point where we can have a discussion about this paper. The outcome data from table 1, so that's the non-TBI, and the TBI paper is the first one, with the first column showing the non-TBI patients and the second being the TBI patients. And then the outcome data in table 2 is the second lower table with all of our TBI patients, all of their TBI patients with standard care or plasma, showing it's a very significant difference in the 30-day mortality, with the whole numbers and percentages in brackets as listed there. So patients that had traumatic brain injury and plasma seemed to have a marked improvement with that plasma. The way they showed this is very appropriately using a Kaplan-Meier survival analysis, comparing pre-hospital patients versus standard care across the subgroups with and without TBI. In the cohort of patients with TBI, there was no significant difference in 30-day mortality. So those without TBI, there was no difference at all, as you can see in graph A here. However, graph B, those patients that did have a traumatic brain injury as determined by this study protocol of having an abnormal CT at time 0 as arrival at hospital, they did go on to have a statistically significant improved 30-day survival if they did have pre-hospital plasma given to them, which is good and opens up the door to a lot of future work probably. If we look at this particular graph, it's a lot of numbers. This is a hazard ratios, and for those of you that are not used to looking at this, like me probably, hazard ratios are reported for pre-hospital plasma compared to standard care on this table here. For hazard ratios at less than or equal to 1 indicate a decrease in risk of death. So hazard ratios greater than 1 indicate an increased risk of death, just so you can sort of interpret those numbers there. And therefore you see the lower the hazard ratio, the better. So traumatic brain injury with mild and moderate traumatic brain injury in other body regions is defined by the presence of TBI and the AIS score above 3. But it's interesting that their TBI of 0.52 shows a significant improvement in mortality, which is great. Discussion-wise, there's obviously a bit more to get into in this paper. Things that I think we should probably talk about at some point, even now or later on when I've gone through the more analytical bits of the paper, is the definition of TBI in the subgroup based on CT. I think that makes it slightly tricky for us as pre-hospital care to provide us to generalize this into our cohort patients that we see, because we don't always have that ability. Well, we don't have that ability in London, certainly. Some pre-hospital systems are slightly different, obviously, but we certainly don't have that ability to have a CT diagnosis. But we certainly have a good idea of who has a traumatic brain injury, but I'm not sure we know actually how good we are at defining that. It's unclear what happened to the TBI patients who died prior to CT and where they fall within this study set. And it's interesting to think about, there might be some exaggerated results in here because people that have some early signs of DAI, those patients that might have very significant traumatic brain injuries, but early on actually might have relatively normal CT scans if they're scanned very early in their journey, might actually fall within the non-traumatic brain injury group based on their study design here, which might confound their findings slightly. They've also looked at brain injury markers, which don't seem to have been that helpful in this particular subgroup analysis. This is a nice little infographic that I enjoyed that hasn't, I'm not really showing you anything here that I haven't already told you. So before, Mike, do you want me to go into the cash critical appraisal stuff now, or do you want to have a pause there and talk about anything?
So why don't we just have a pause for a second to see if anyone has any initial thoughts or impact or impressions on the paper, and just for some of the people, because we have some non-clinicians on the call too, so just some of the acronyms. I know it's okay, just for some of our more data-oriented colleagues and others, so DIA is a diffuse axonal injury, which is basically like shaken brain syndrome, but doesn't necessarily show up with a big blood clot on the brain that we sometimes see. But yeah, were there any just sort of first glance, because I think a lot of people read these trials and then don't necessarily actually always go into the full critical appraisal. But it'd be interesting to see if I had better Zoom skills, I would put up a poll, but I haven't figured out how to do that yet, to see whether people would, based upon the information they have at the moment, change their practice or not, or whether they have other things they're still thinking about. So if anyone has any comments at all or thoughts you want to share at this point.
Can I speak, Mike? It's Jake.
Yeah, sure.
Well, to answer your question, firstly, and then a question for Rob, if that's all right. I think, this kind of fits with what we're starting to understand about brain injury and some of the other trials that have come out recently. I know that the ITACTIC trial demonstrated that in brain injured patients, actually really carefully controlling people's clotting and turning lots of attention to that seemed to have quite a significant impact on that subgroup as well. And I guess this fits with that, which is reassuring and suggests that perhaps this is actually meaningful, because I know this is one study, but other studies seem to be agreeing with that. Rob, can you just go back to you had a slide with the outcomes, the yellow table with keep going back. Keep going back, mate. That one there. So this is more of a question really to do with the original trial, but do we think that when they analysed the original PAMPer study, did they exclude brain injured patients to determine whether or not plasma was still beneficial for their traumatically injured patients? Or do we think that the brain injured patients in their original study have skewed their results to show that it's beneficial, but actually maybe it's all these brain injured patients that are doing much better, and that's actually where the mortality benefit was?
Yeah, so in the initial PAMPer study, the only patients excluded were those with penetrating brain injuries. I'm pretty sure that all other were kept in.
Okay, and did they do any analysis to look at if they took all the brain injured patients out, did they still show that mortality benefit with plasma in those shocked patients?
I don't actually know the answer to that, but not sure.
Yeah.
Mike, do you know the answer to that?
No, I don't think it would be a little unusual to do an analysis like that. That would be sort of from the subgroup kind of analysis. And they do talk about in this analysis whether or not how much weight this subgroup may have played on the overall effect or not. But
they did do that, did they? They did look at that.
Well, they mention it. They sort of hypothesize that, as you'll see, because the relative risk reduction here is actually far higher than it is in the original trial. So this is actually a 50% mortality reduction here versus only 10% in the original trial.
Yeah.
So it suggests that a lot of that difference they observed in the overall trial may be driven by this subgroup of patients.
Yeah, that's what I was wondering. Okay, that's interesting. Thank you.
Anything else from anyone?
Hey, it's Jan here. Just one question I had was just around the timing. I'm still trying to figure that out. It seemed to address a little bit of it when they talked about the transport origin as a proxy, the time that plasma was administered. So saying that to the secondary transfers or interfacility transfers versus the pre-hospital or primaries didn't have the benefit that the pre-hospital ones had. But it'd be really nice to know actually how long from the time of injury to the time of plasma administration actually occurred. And, unless I'm missing it, I don't see it anywhere here.
Yeah, I totally agree with that. I don't think that is in the paper, mate. I haven't seen that at all. I have to say I haven't been through every single appendix. I haven't had time, but I don't think it's in there. Mike, have you seen it? I don't think you have.
No, and I went through the online appendix, and I don't remember seeing anything about times in there. And in their paper, they actually kind of discussed that the best they could do as a surrogate was this. So I don't think they actually collected that that detail.
Yeah. Yeah. Anything else? Or should we move on?
Yeah, why don't we keep going, and then we can get into the meaty part of the discussion.
Sure. Yeah. So with respect to looking at the analysis of this, we have done a critical appraisal skills, or a CASP, of the actual paper, and then also using the JAMA have a particular way that they think that they advise to look at the subgroup analysis papers to make sure that we're actually looking at them in the right light. So we're just going to skip through some of the questions we might ask ask on just some opinions on my opinions, I guess, on this paper, and also the previous PAMPer paper that do inform this paper. So did the study address a clearly focused issue? It probably did, yeah. Was it recruited in an acceptable way? It probably was for PAMPer, but for this is a subgroup analysis. It wasn't completely recruited for this purpose. Was the exposure accurately measured to minimize bias? You can't actually tell whether they've removed all the possibilities there, and the outcome accurately measured bias. There are some areas within it where they could certainly have improved. Have the authors identified all important confounding factors? You can't really tell, because I think there are some patients that get mixed up into the different groups here, but I do think they have taken into account within their analysis plan, and their actual groups are fairly even. So I think they've done what they probably can to take into account confounding on the whole here. Was the follow-up of the subject complete enough? It was pretty good. They looked at a lot. They didn't have much loss to follow up. They could have looked at further outcome data over a longer period of time, but on the whole, I think it was pretty good. Do I believe the results? I'm not sure if I think I probably do, based on all the other stuff that's coming out, but I don't think from this the subgroup analysis in isolation, I don't think you can completely believe the results until further studies are designed and conducted. Are they applied to our local population? I don't think at the moment they are, but I don't think you can tell either way. So I think there's this, as a lot of subgroup analysis do, I think they just ask more questions than anything, and do the results of this study fit with an available evidence? I'm not sure you can really tell that either, but I think we will know when, I'm sure someone's designing an RCT based on this as we speak. The subgroup analysis, these are the sort of questions when you look at a subgroup of an original paper that you need to look at. You need to think about, can charts explain the subgroup difference in the paper? You said, is the subgroup difference consistent across the studies, and then work through them. I'm not sure that charts, we'll talk about it in a minute, but I don't think charts probably can explain this difference. It's so marked, and there might be some element of exaggerated results in this because of the way they've designed it and conducted the subgroup. However, I don't think I think there will still be a difference. Based on the animal work and the retrospective work that others are doing as well, I think there is likely to be a difference. Is the subgroup a difference consistent across the studies? It's in keeping with some studies, as we've already sort of mentioned. However, we certainly need more, and we need more prospective RCTs to actually answer that question. And was the subgroup difference one of a small number of prior hypotheses in which the direction was accurately yes, I think it was probably. And is there a strong pre-existing biological rationale supporting the apparent subgroup effect? Yeah, I think there probably was as well. And that's sort of the way that you need to look at it all, be it this is the basis of a discussion we're going to have now, but it'd be good to focus our discussion around these when we're thinking about this particular subgroup analysis. And I'll leave the bottom line out at the moment. Should we get into the nitty gritty of the conversation, Mike?
Yeah, sounds good.
Where should we start? Who wants to kick off?
So I guess maybe I'll start by asking a question in terms of and I sent around the link to the JAMA article that really nicely walks through the examples of subgroup analyses and how to really appraise them and why these issues are raised. But this paper, and they do a very good job in this paper of stating again and again that the hypotheses, that the findings here are only hypothesis generating. And I think, in a minute we'll go through and discuss the sort of why that is the case and how, even though this is part of a fairly robustly conducted RCT, that we can't then take this as evidence in the same type of way. Rob, did you want to are you planning on delving any more into the other points that you raised earlier about how the CT issues and stuff like that, or?
No, I haven't got slides on them because I haven't had time to create any more slides. But I was going to, we're going to have a conversation about it. Yeah, but feel free, Mike, go for it.
Yeah, no. Why don't you start sharing your thoughts on those, and then I and others can jump in if we have comments or questions on that, because based on the discussion we already have, I think.
Yeah, sure. Yeah, sure. I think one of the things I was quite surprised when they changed how they defined TBI patients as requiring CT. And I think that's how they make the diagnosis and how they allocate these patients to within their study groups. I think that makes it quite difficult, given it's a pre-hospital trial, for us to generalize the findings, therefore, to the pre-hospital stage. So I think that's one thing that I think makes it pretty tricky. And the other thing is that I think I don't think it's not clear from me, like I've already said, it's not clear from me from the design of exactly what they mean by CT diagnosis of TBI, and we're not entirely sure what they mean by that, whether that's only significant pathology, and that's where my concern is around the diffuse axonal injuries or the patients with relatively normal CT heads or hypoxic brains or things like that are not going to be necessarily picked up in this CT group. And I think that's what we talked about before, Mike, wasn't it? I don't know what other thoughts you had on that.
Yeah, so there's a couple of things. So did you point out, so there's the issue of generalizability about not having CTs. If we don't have a CT in the pre-hospital field, we can't initially say for sure this patient, matches that same criteria. So as we usually would have generalized from a study. But the more important thing around the CTs for me were a couple of issues. One is their lack of clarity as to how they manage patients that don't have a CT. So if a patient died prematurely and didn't have a CT, they don't make it clear as to whether or not they counted that patient in the no TBI group or in the TBI group, how they handled that distinction. And that's where issues around randomization and intention to treat analysis start to come in. That's different in a subgroup analysis, because in a regular randomized trial where they randomized early on, and you do that to try and use chance and a sort of a distribution to control for any factors that you can't measure and any confounding variables that may exist within the study. And then if you continue to analyze any patients in the group to which they're analyzed, you'll also kind of sort out some issues such as varying lengths of follow-up. And if you have a patient who potentially, for instance, was randomized to the treatment arm but dies early, you still count their death in the intention to treat arm, because otherwise you may bias one way or the other your treatment. If you take basically, this comes down to some stuff we've discussed in prior journal clubs, that if you take all the bad events and put them in the non-treatment arm. So for instance, the classic thing comes down to surgery. If you're about to have endarterectomy or some surgery and you happen to die from your disease before you have that surgery, a lot of surgeons would say, well, we should not count you in the arm for the intervention. But if you do that, then you have patients who if they would have naturally died anyways before they got to that surgery, you're just taking all the bad outcomes and sticking it in the control arm, and then your stats look really good for the treatment. And if they did that here with patients who had a potential head injury but died pre-hospitally or early in hospital admission before they had their CT, if they all got stuck in the non-TBI arm, you can suddenly see how it's going to disadvantage that group and make your treatment with plasma look really good. And we don't know how they handled that. The other point around that and the issue around diffuse axonal injury, which doesn't obviously, as we all know, show up on a scan, especially an immediate scan when you arrive in the emergency department, always as obviously as a big bleed or contusion and stuff like that in your brain. But those patients may have quite significant brain injuries. And the reason that comes up is because if you look at their table 2, about 30% of the patients in the non-TBI injury had a GCS of less than 8, which to me seemed a little high for patients that are being said to be non-brain injured. You certainly can have that with some shock and things, but they actually report that they had more multi-organ failure and more shock in the TBI group and the non-TBI group. So that, and some of those things start to come up and make me go, okay, is there more happening here? And this 50% reduction is almost like a miracle cure for traumatic brain injury, which, as we know, we often see due to a bunch of statistical reasons and stuff that effects in subgroup analysis are over-exaggerate when we actually go on and do a full randomized control trial. So those are all the things that, though there is the biologic plausibility and a bunch of other issues, there's a number of these things in the subgroup analysis that make it harder to necessarily say that that this is definitely an effect that we would see if we did a proper randomized trial, but also how the magnitude of that effect. It may be much less of a potent effect than we've measured here. Is I'll stop talking and see if anyone else had any questions or comments about this.
Take it off so we can see each other. There we go.
Look like you're about to come off mute, Jake, but he's not. It's too bad Flora wasn't here. I was hoping she would have been able to join us. Jan, did you have any thoughts? I know you're using plasma and blood there or you're using blood and about to be using plasma blood, I think, in BC. What were your thoughts on this?
Yeah, thanks, Mike. We've been using Parker blood cells for almost 2 years now in emergency formats, and we'll be rolling out plasma pretty soon. And this was one of the studies that sort of encouraged us to keep going with that. The issues with it, as you point out, are issues, but I'm not sure that we're going to be able to target the plasma towards the patients as they are kind of, I wouldn't say doing in this study. But we would probably be using it. Well, we will be using it in a more blanket fashion for patients with significant trauma meeting specific indications. So I guess on the whole, this one not perfect, but it does lend a bit more signal that maybe there is benefit to using it. So we'll tend to be leading with plasma. The best I can say right now. I don't know, Adam, if you had anything else. Just to let everyone know, Adam Green is one of the critical care paramedics here in British Columbia, who I was able to drag into this session at the permission of Mike as well. So, and I apologize for his mustache. I don't know if Adam, you had anything to say there?
No, first and foremost, thank you for having me. I think right now it's an interesting subgroup analysis. But right now, I'm not sure how generalizable it is to our practice, as I think for all the reasons Jan has pointed out. it's also just so early in our program that to start being so specific may actually just cause us more tripping points. So yeah, it's interesting. What I've learned in the last probably 6 months that's interesting has been when these kind of questions arise about definitions of DII, I've actually just been reaching out to authors, say, can you fill me in here? So I'll take the lead and I'll actually just reach out and see if I can get any information, see if they can better define it for us, and I'll send it back to the group.
All right, thanks, Adam. And Harriet, coming from another plasma pack cell service, did you guys have any discussion about this down in KSS yet?
Yeah, I mean, we had similar discussions about the implications, whether we could directly transfer the findings to our patient population. I think we were wondering whether, because we're doing something rather than nothing in a similar way with ITATIC, I think it's the first time that TBI has been actually treated, for want of a better word, rather than just transferred for sort of secondary prevention and ongoing sort of care by neurosurgeons if appropriate. So I think this might be a bit of an effect of something rather than nothing, rather than a definite positive benefit. But I think that we were having ongoing discussions with me whether we should change our SOPs for isolated head injuries. Should we be giving Lioplas rather than nothing? And that's with ongoing discussions at the moment, I think.
Yeah, and I think one of the other things, and this is a little bit of a highly select group in that we're all pre-hospital providers. I think one of the more interesting questions from this is as Jan alluded to a little bit about this, the data around pre-hospital versus primary versus secondary transfer of these patients, and the degree to which this benefit may be an early benefit effect, and whether or not, it may be less of an interest for us in terms of shifting our practice, particularly if you're already treating with plasma and pack cells in London, and places that are considering whole blood versus plasma pack cells may be a more interesting question for them. But even more, I think, for people that don't have any blood products pre-hospitally and rely on them purely for use in secondary transfer, whether or not this is starting to suggest at least the need to look at that, moving that earlier in the echelons of care. So that will be, I think, as I agree with Rob, it's pretty much certainly an RCT that's powered specifically to look at TBI being worked up somewhere, and it will definitely be a very interesting result. But they'll definitely have to go back to for the pre-hospital phase using some type of non-CT based diagnostics. The other thing that you mentioned was the brain injury markers. So here's another one you can ask them, Adam, while you're when you ask your question. If we haven't had time to write the authors, and I don't know any of them, so I don't think I know any of them. I didn't go through the entire list, so I wasn't able to fire off any emails. But they discuss a few times in their paper, in two different places, both in the results and then in the discussion, this issue that they also use markers of brain injury severity, so some biomarkers of brain injury. And they keep on saying that they were the same across all groups, which is a little unusual, because they say that they talk about how well they're correlated with the fact that you have brain injury and things like that. But then it's not entirely clear whether they're referring to across all of the brain injured patients and non-brain injured patients, or across plasma versus non-plasma patients, which also gets to, because if they are truly the same across all their patient groups, that suggests that they haven't actually managed to tease out the two different groups adequately, and that may be the issue around DAI or some other type of brain injury that's not falling into their definition, and may account for it's not just all TBI patients, but a specific type of TBI patients, largely the ones that are bleeding into the brain that you can see blood on their brain, who are going to benefit from this, and other types of brain injured patients who may not. So it'd be interesting to know what their thoughts are around the markers and why there wasn't a difference between the various groups. Rob, did you have anything else you wanted us to to cover in this?
I don't think I did, no. I think that was everything, unless anyone's got any other points.
Any other questions from, I think Tom had to leave, so he's not there now. So I think this was, you know, on the face value, when you first look at this paper, it's like, oh, wow, this is and plus the fact that, you know, managed to get a JAMA publication out of it, quite an impressive, you know, looking paper that, you know, it sounds like, you know, a very powerful treatment or potentially very good treatment for this. But I think when you start to dig into it a little bit, we just have to be really careful to appropriately set our expectations about this being just a secondary analysis, and ask more questions before we certainly make any big decisions around changing pathways or clinical treatments. That was a fantastic review, Rob. Thanks for your time doing this. And I'll leave the last, oh, Jan has a question.
Just if we have time, I just wanted to sort of get a general idea of what people are doing or what their opinions are. One of the things that we're dealing with here in British Columbia, so our format within responding to patients is, you know, from a geographical standpoint, is huge. So it can be anywhere from, say, flying across London as a distance or flying to Germany, that kind of distance. So the time responses are quite varied. And one of the things that we wanted to figure out, because we're now going to be carrying plasma and packed red blood cells on board the aircraft, is which to transfuse first. We ended up settling on transfusing the plasma first, the 2 units, and then the 2 units of packed red blood cells after that, if the patient still required it. Partly because of the signal that maybe there's some benefit to the pre-hospital plasma, but also because they're trying to deal with wastage rates. So once you've thawed the plasma, it expires in 5 days, and it's harder to recirculate back into the system, the major trauma hospitals, and without losing units, precious units, which Canadian Blood Services looks very carefully at and will shut a program down if it starts wasting a lot of product. But I just wanted to get opinion on maybe some of the other systems, because KSS is in here as well, about what, because your transfers are bigger or longer than London, how you're approaching the plasma packed red blood cell, I guess, equation.
So we carry lyoplas rather than pre-thawed FFP, so it's slightly different in terms of wastage. But our SOP, if you're not imminently sort of TCA and needing urgent blood, is to give plasma first, and that has been that for as long as I've been working there. I think they're trying some new stages, but at the moment our first resuscitation fluid would be lyoplas. If you have time to give that, spin lyoplas, give that, then give red cells.
Did you catch that, Jan?
Yeah, I got that. Thank you, Eric.
Yeah, I think it does make a difference depending on whether you're using thawed plasma or never frozen plasma or lyoplas. I think some of the lyoplas things are more around the logistics of mixing it all up and the time it takes to do that. But services that, at least that I'm familiar with, that have plasma, and certainly back in the military, the doctrine was always plasma first and then packed cells. So, all right. Well, thanks everybody. It was good to see you, and yeah, this will all get posted on YouTube, and well, it's our internal YouTube. But if you want the link, let me know. We can always share it. So thanks, Rob, and we'll see you all. We probably won't be doing this in December because it's going to be just the week before Christmas. So we'll see you in the new year. All right. Bye-bye.
See you soon. Bye.
Thank you.